Hello, and welcome to the Neurocritical Care Society podcast. This is our Perspective series. I'm your host, Dr. Nick Morris from the University of Maryland Shock Trauma Hospital. And with me today is a very honored guest, Dr. Daryl Gress. Dr. Gress is a professor in the Department of Neurological Sciences at the University of Nebraska Medical Center. He received his MD from Washington University in St. Louis, attended Johns Hopkins University in Baltimore, and was chief resident at Massachusetts General Hospital in Boston, where he also completed his fellowships. Prior to coming to Nebraska, Dr. Gress held academic appointments at Harvard Medical School, the University of California, San Francisco, and the University of Virginia. And we're really excited to have him on the podcast today because Dr. Gress played really a key role in my mind, as I understand it, of bringing neurocritical care out west to the West Coast, to UCSF. And Dr. Gress, welcome to the podcast.
Well, thank you for having me.
So maybe we can start sort of at the beginning, as they say. How did you get interested in neurocritical care, and what's kind of the origin story of Daryl Gress?
It's always hard to know. I think sometimes the career takes you in a direction about as much as you try to plan where you want to go. I wouldn't have guessed that was the case. But I think for me, I started with a internal medicine residency at Hopkins before moving up to Mass General to do neurology. And I had planned on doing that. It seemed like that's what one should do if you wanted to be, quote unquote, a real doctor in those days. And then neurology happened, and there's a lot of excitement in that. Putting the two together and having a mentor like Alan Roper at your side, it just happened.
Yeah, I had the same experience. Alan Roper was my mentor, and I think he's one of the people who really got me excited and interested in this field. Can you maybe talk about was there any particular experience with Alan or at Mass General that really pushed you into neurocritical care?
It seemed like that was the piece of neurology that I was most comfortable with, perhaps related to being comfortable with internal medicine and ICU work and things that, compared to some folks in neurology, it seemed like my home.
That's interesting because at that time there weren't too many neurocritical care units across the country. So I don't think many neurology residents found a home in a neuro ICU simply because they didn't exist. But you played a key part in bringing neurocritical care to other areas of the country. So can you take us from your early experiences at Mass General, and then how did you get started in leaving Harvard Medical School and Mass General and bringing neurocritical care elsewhere?
I had done a stroke fellowship with Phil Kissler, and Steve Miller-Fisher was still there at the time, and then a neurocritical care fellowship with Alan. And Alan left Mass General, so I became head of neurocritical care there. And for a couple of years, everything seemed pretty content in my life. Then I had an offer to think about going to UCSF. This was sort of a big step, but they were all people that I knew. My old department chair, Joe Martin, had gone to UCSF as chancellor, and he had recruited Steve Hauser, who I liked working with a lot as one of my attendings. Steve went to be chair of neurology. He wanted me then to come and start stroke, actually, at UCSF, since they had neither a stroke service and certainly nothing in neurocritical care. And I didn't want to leave neurocritical care, but it seemed like a great opportunity. For one thing, it was March in Boston and snow was up over your mailbox. And I flew out to UCSF and they took me to the VA hospital there overlooking the bay. The flowers were blooming, the sun was shining. I went home and told my wife that we just have to go back and look at this again. But it was, as everyone knows, it was a great department, but lacked some of the clinical subspecialties, certainly stroke and neurocritical care. So I told him I would be willing to think about going to do stroke, but I had to be able to do neurocritical care as well. So we started with the idea of trying to do both, and that was the definition of the UCSF neurovascular service, basically, is that it was an ICU-based stroke service. And so we did neurocritical care and stroke care. At Mass General, I had spent a lot of time with the early neurointerventional work that was done there by John Pyle Spellman in a time when there really wasn't much neurointerventional either. And so when I went to UCSF, it seemed reasonable, since there was a big neurointerventional group there, that their patients could come to my service, since neurosurgery was tired of taking care of their patients. So we sort of had an instant clinical base with all of the neurointerventional patients coming to the ICU were on the neurovascular service. So we managed 100 subarachnoid hemorrhages a year on our service, and neurosurgery had their share. It was busy. I had negotiated to have a fellow and one faculty member to hire, so there would be 3 of us, but it was still pretty busy.
Of course.
There were, the first fellow, of course, was Claude Hemphill, who people probably still recognize. And
yeah, you picked a good one there.
The first junior faculty member was Wade Smith, who had just finished a pulmonary anesthesia-based critical care fellowship, and then joined me to work in neurocritical care. So it was a busy time, but I had amazing help with those 2 guys building the service.
Can you talk a little bit about how did you, this incredible perspective that we can get from you? How did you train Claude? What was a fellowship like then?
I'm not sure I trained Claude. Claude is a great guy. He worked hard with us. I started the fellowship there with Claude as the first fellow. Anesthesia critical care with pulmonary critical care had a common 1-year fellowship before they split off to do anesthesia and pulmonary. And I thought that it was a perfect opportunity to do the same with neurocritical care. So Claude started with a year of critical care medicine through anesthesia and pulmonary, and then did a year of neuro stuff with us, not necessarily all at 1 year of each in sequence, but mixed together at least, so that he did have a year of critical care time. And I think it set the stage for a lot of what Claude went on to do at San Francisco General, where he was an accepted part of the trauma service because he was critical care competent. My goal was to certainly sustain, if not increase, the amount of critical care medicine that was part of many of the fledgling neurocritical care programs at that time. I didn't want to have people come out of the program just as neurologists comfortable sitting in an ICU. I wanted people to be card-carrying intensivists. And so Claude got a pretty hefty dose of critical care, and subsequent fellows stayed in that same mold of 1 year of critical care and 1 year of neuro for our neurocritical care fellowship.
Yeah, I think that's really important, and I think was tremendously helpful for the eventual acceptance of our field and within the critical care community. So I thank you for that. We've taken that model really here at Maryland in many ways, and our fellows rotate as the primary fellow in the medical ICU, surgical ICU, et cetera. And I think that we probably owe that tradition to you in many ways. Could you maybe contrast that a little bit with the training that you underwent at Mass General? And I'm sure you built that model for a reason based on your own experience. So maybe how were your experience different as a fellow?
Remember that in those days, there was really no such thing as organized fellowships in neurocritical care with specific goals. And I basically spent a year with Alan Roper, following him in the ICU and learning through being clinically active with him. And that's kind of where it was. I had done a lot of critical care at Hopkins as part of my medicine residency, so I was actually pretty comfortable with all of that stuff.
Mm-hmm.
So in my mind, I sort of had a year of critical care medicine and a year of neurocritical care, at least in the experience.
Right. That's a big difference from a lot of our trainees now who come from a neurology background with only 1 year of internal medicine. Maybe we can come back to that later and think about how your views on training fellows have changed over time. But now I'm interested in hearing a little bit more about the development of the neuro ICU at UCSF. So you were recruited there. There was kind of these neurointerventional patients that were there for the taking. But how did you grow from one fellow, one junior faculty member to what it was when you left, which was really a well-renowned and thriving neuro ICU?
The patient populations were clearly there. This stroke world, at the time I went, most of the strokes were on internal medicine, and neurology was something more of a contemplative sport at that time, and stroke was not very exciting. We changed that, and the stroke piece became big. Of course, I went in 94, and then in 95, TPA hit the world, and so it was an explosion of stroke as well. I have always sort of said, sort of your first step when you go someplace is you have to put in the time to develop clinical credibility with the local clinicians. They have to see that you're willing to take care of patients, be willing to walk the walk. And we suddenly found the cardiologists sending their stroke patients to us, and it grew fairly quickly. When I went, the census on the general inpatient neurology service was about 150 a year. By the time I left, we had over 500 a year simply on the neurovascular service.
Mm-hmm.
And that required significant amounts of extra manpower. So I was fortunate enough to have the support. Basically, we kept most of our fellows. We were growing at one or a year or so. We got to be able to have two because we had a lot of clinical activity, but we also were fortunate enough to have an endowed neurocritical care fellowship at that time. One of my patients gave a donation for our training program, Ken Rainin, who had been involved, as most people know, the Rain Man pipettes. That was one of Ken's companies. And he enjoyed meeting with the fellows every year and hearing what they were doing. And so we had two endowed neurocritical care slots, which in those days were a big thing because nobody really had money to support critical care fellow salaries.
Mm-hmm. Wow, that's incredible. I didn't realize there was an endowed fellowship. How many incredible intensivists came out of that endowment? It's really mind-blowing that maybe one person's gift had such an impact.
I think that was, once we captured Ken's thoughts in that, he really enjoyed that. He's a great guy.
Yeah. What were some of the unexpected challenges or barriers to developing that ICU?
I think the biggest challenge was trying to keep up with the workload with the growth of the service, because we also had to establish an outpatient clinic both for neuro ICU follow-up and also for the stroke patients. So it was a big challenge to do. I think that was the biggest thing. We were fortunate to have great support from Steve Hauser as chair, and perhaps surprisingly, one of my biggest supporters was Charlie Wilson, chair of neurosurgery at that time. One hears stories about how Charlie's temper would sometimes become an issue, and one neurosurgery resident wouldn't be around the next week, but he was incredibly nice to me and recognized the benefits of having neurocritical care and take care of his patients. I think I had great support.
You mentioned sort of the early mentorship of Alan Roper. I'm wondering, as you developed this ICU, who else did you turn to for advice or mentorship at that time?
I probably wasn't smart enough to look for mentorship. I'm not sure I talked to anybody much about stuff.
Fair enough.
Weren't a lot of people around.
Yeah, it's curious. I mean, now we have, thanks to people who sort of broke the ground for us, we have so many people who have experience that in early and mid-faculty people can turn to. But you were really a trailblazer at the time, so there weren't too many people who had experience doing what you were doing. I'm interested a little bit in sort of the structure of the way the neuro ICU was set up with the neurovascular service. For those who aren't familiar with the UCSF model, can you summarize that a little bit and maybe explain why it was set up that way? And I believe it continues to function in the same way.
It's pretty similar. I think most places, the precise structure has a lot to do with local issues on the ground as it grew. And that's true if you go someplace now, the only way you can kind of understand why it looks the way it looks is to understand the history of it. I had wanted to do both stroke and neurocritical care as part of my plan to build services there. So we started together. I was also fairly clear that eventually those two subspecialties need to develop their own identity. And it happened fairly quickly with us. With Clay Johnston was a fellow with me, but Clay was mostly interested in stroke. So his fellowship really didn't include the neurocritical care piece. He spent 2 years with us in stroke. Because the two really are different and have kind of tended to have people interested in more one than another now. Although I think that the neurovascular service still maintains a big focus on stroke, which is perhaps a little different, but I still think the idea works.
Mm-hmm.
May not be for every place, but it works in San Francisco.
And am I right in saying, if I remember, the neurovascular service there will follow those patients even if they're downgraded outside of the ICU? Is that correct?
Yeah, I think that's pretty much required if you're going to do stroke.
Yeah,
in my view, and into the clinic. So we provided outpatient care as well.
And did you follow up with the hemorrhagic stroke patients as well?
Yes, and subarachnoid hemorrhage.
Okay, so that's I think another way you all were a bit ahead of your time. There's a lot of talk now about neurocritical care follow-up clinics or post-ICU clinics, but it sounds like you've been doing that or started that, decades ago.
I think it's really important for lots of reasons. It's good patient care, and I've always contended that if you want your neurointensivists, your fellows, to learn how to have conversations with families about goals of care and what may lie ahead, it's pretty difficult if they've never actually seen what subarachnoid hemorrhage patients look like in 6 months, or listened to families talk about the difficulties with head trauma or difficulties getting back to work. If you haven't been part of that, I don't know how you can learn to have those conversations.
Yeah, I agree. I think that's very, very much in line with where we're starting to think, and as we train our fellows now, that they need those outpatient experiences to understand the longitudinal trajectories of disease and recovery, and to make sense of all of this in a way that can be meaningful to patients and their families. Um, I'm I'm wondering, as you kind of reflect back on your career, and as you've moved from San Francisco, and then it was University of Virginia, correct? And now to Nebraska. In broad strokes, what are some of the major changes that you think have been for the better in the field, and what are some areas where maybe we could benefit from looking back and going back to some of the earlier practices?
Certainly in the day-to-day operations, there have been a lot of changes with the resident involvement. I was a big believer that you had to have residents in the ICU overnight and stay for rounds so you could understand what happened, that resident involvement was key. It's clear that there have been lots of changes with that in a way that it's very difficult to have the same kind of resident responsibility and continuity. We've tended to shift to APPs as well, and in some ways that makes life easier. They are able to become neurocritical care specialists in their own right. That way you don't actually have to talk about the loading dose of phenytoin every 2 weeks.
Right. That can be helpful, not to repeat yourself.
I think in the end, patient care continues to be delivered in a great fashion in neurocritical care, in large part, I think, because neurointensivists are true clinicians. Compared to some of the other critical care specialties out there, pulmonary critical care, a lot of people spend as much time in pulmonary and a few weeks a year in critical care. I think most neurointensivists tend to be full-time neurointensivists, which is good for the field.
Yeah, that's true. I was speaking recently to some, let's say, more experienced neurointensivists, and we were talking about sort of aging in neurocritical care, and that many of our colleagues, as you suggest, they may do a lot of outpatient time in pulm critical care, and we seem to watch them sort of transition from being intensivists to being pulmonologists at times. Perhaps we see that with some of our anesthesiology colleagues who end up spending more time in the OR and less time in the ICU. If you seem to have spent most of your career in the ICU, I'm wondering if you have any advice for those of us who are wondering, how do we keep this up for the next 20 to 30 years?
I remember yet when Alan Roper told me that neurocritical care was a young man's game. And I looked at him and I thought, well, I'm a young man. I've got no problem. I've thought about that because I certainly am no longer a young man, but I think that I wouldn't want to be doing anything else. I think you can do this. I still do 20 weeks a year kind of stuff. Now I'm probably, since we started a neurocritical care consult service here, and I've been able to recruit some additional people. The younger people like the excitement of the ICU, so they usually give me the consults, but I still like the intensity of neurocritical care. It's one of the few places that I think you still have that intensity and individual clinical approach in patient care. Stroke has become quite protocolized and regimented.
Mm-hmm.
Neurocritical care, for better or worse, still does not have adequate data-driven algorithms for everything. A lot of it is still a clinical challenge. And what I love about the ICU work is that rather than titrating Cinemed over 3 months, you get a couple of hours to make an assessment and intervention, reevaluate, and if you like what you did, you do more of it. If you don't like what you did, you try something else. And the time constant is very short,
Yeah.
and it just suits some people, and I happen to be one of those.
Oh, well, me too. Um, what are some ways that you maybe have changed as a neurointensivist over the years?
I think that I probably have become more concerned about the intensity of acute interventions and things that we feel fairly certain are not going to generate good outcomes. Like most things, I've always said that everybody deserves acute intervention up front, hoping for that good outcome. But once you realize that that didn't happen this time, you also have a responsibility for helping manage expectations and outcome. One of the things I have tried to teach is that as the clinician, you make decisions about doing something or not doing something, but that ultimately you were responsible for the outcome either way. It actually isn't safe to just say, well, I didn't do something, so I'm not responsible for what happened.
Mm-hmm. Mm-hmm. Yeah, I think that's
You
a really
need to
profound
feel
point.
you need to feel the responsibility either way. Claude and I have had these discussions a lot, and I think he's come to understand what I mean in that. It's easy to say, well, I didn't do anything, but that
Right.
might have been the problem.
Yeah. Yeah. We certainly we carry a large burden of responsibility for our patient care, and I feel that as well, that it's not just what we do, it's what we don't do. Sometimes I try to convince my neurosurgical colleagues of that as well. I think that's a tougher sell, but I certainly feel it sort of in my core. Um, what what excites you about the future of neurocritical care? What are you looking forward to?
I think the future is very bright. There are days that I think I'm doing the same thing I did 25 years ago about some things, but I can see some glimmers of light. And the thing that I think is the most exciting is to think about a day when we understand the signaling and the control of reorganization and neurorecovery in such a way that we can augment its recovery. We see sometimes that people have remarkable recovery and we don't know why, but we still don't know how, even what the signaling mechanisms are for reorganization. And understanding that, I think, is the most exciting thing.
And in your opinion, what's been the biggest breakthrough in neurocritical care in your career? Was it TPA? Was it thrombectomy? Was it some other aspect of care?
I grew up at Mass General and on with aneurysmal subarachnoid hemorrhage as my sort of favorite
Hmm.
neurocritical care disorder. I used to say the great thing was they kind of come and stick for a couple of weeks, so it's good for the ICU.
Yep.
But the development of coiling and interventional work in aneurysmal subarachnoid hemorrhage has been phenomenal. I grew up in the beginning with Alan Roper, where surgery was considered at day 14, and you had to try to get people to survive. And I remember a lot of times, day 10, day 12, there'd be a recurrent hemorrhage and you just lost.
Yeah.
So for me, the most remarkable thing is how the treatment of aneurysmal subarachnoid hemorrhage or even unruptured aneurysms has changed. I see basilar tip aneurysms come in, get coiled, and go home the next day.
Mm-hmm.
People haven't seen what surgical approach and clipping of a basilar tip aneurysm is really like. They ain't going home the next day.
Mm-hmm. Yeah, that's another really good example of feeling that responsibility of not just what you do, but what you don't do, right? If you don't secure the aneurysm, and you have a rebleed on day 10, that burden of responsibility falls on all of us. Yeah. So we talked about kind of what the biggest breakthrough is. What about the biggest frustration? What's the area you said sometimes it feels like you're rounding in the ICU and it's the same as it was 25 years ago? Any areas where you're just really frustrated that we haven't been able to move things forward?
I think probably traumatic brain injury is one of those that frustrates me. And when I try to talk about developing multimodality monitoring and stuff, people will say, well, there's no data to show that even ICP monitoring improves outcome. And you just kind of have to grit your teeth because it's true.
Mm-hmm.
It just, we still haven't gotten there yet, but it's going to happen.
Yeah. I was at the AN conference a couple of weeks ago, and I was talking to some of the authors of, I think it was 2015 when NCS came with its first multimodality consensus statement. And I was asking them, what's changed?
Mm-hmm.
Because we're coming up on the 10-year anniversary of that piece. And so, yeah, I feel that frustration as well. Well, that's great. As we look forward, and we've talked a lot about training now and the role of residents in the ICU and the training of fellows. As we've become now an ACGME accredited fellowship in neurocritical care. Have you reflected much on the way that training is these days and how we should be training our fellows? What are, as you see it, the key components of a neurocritical care fellowship?
I think that the challenge is melding how we have traditionally trained fellows into something that's ACGME compatible. I think that we've done a good job training fellows with an emphasis on critical care, with an emphasis on bedside neurocritical care experience. I think we're doing okay. The challenge is maintaining that with all of the rules. It's hard to get in enough critical care months to suit me. We've just been planning our ACGME fellowship here, and I keep saying, well, but we need more months. It's hard.
Yep. We're facing the same struggle here. We're just looking at the months and figuring how do we make sure that people have their required elective time and that they are feeling that their wellness is being looked after, but that they're going to be adequately trained to take care of the sickest patients. It's really hard in 2 years.
And when did fellows start expecting a month of vacation? Is that we need another.
It's challenging.
Mm-hmm.
Absolutely. And just to wrap up, I'm wondering if you could share, is there a clinical story, a case that you took care of that really has made a lasting impact on the way that you think about either your own role in the ICU or the role of neurocritical care?
There have been a few. Perhaps the one that I talk about most is the young woman I took care of here at Nebraska with the anti-NMDA receptor encephalitis that I struggled mightily with. She was essentially in barbiturate seizure suppression, burst suppression for 5 months.
Mm.
And it took a lot of faith in what you thought you were doing. It took a lot of tremendous nursing to get through. But this woman now is essentially normal. I won't say she might not have some short-term memory difficulty if you really looked, but she has a normal life and wasn't really something that I felt I knew was going to happen, but I just couldn't stop.
Yeah.
I learned you have to just be patient.
Yeah, well, certainly that is an area where we've made tremendous progress is understanding some of these autoimmune encephalitides and how to manage them. Reflecting back, were there cases you can now think of earlier in your career that, you definitely, this was most likely an NMDA receptor encephalitis or something like that, and we just didn't know about it at the time?
Absolutely. I think there's no reason to think that it's a new disease. I'm quite certain that they would have been diagnosed as non-herpetic viral encephalitis, not otherwise specified.
Mm-hmm, mm-hmm. Yeah. Do you think that other than obviously the treatments, did it change the way that you thought about, as you said, kind of holding out hope, or when you sort of declared futility?
I think it made it harder.
Yeah.
And I would never claim that I understand the rules around that. I am quite certain I have made mistakes on both sides. What I try to say and what I try to do is to be honest with myself and honest with patients and their family. But it's not a perfect science.
It is far from a perfect science. Well, this has been really, really wonderful. We always end the interviews with a few sort of quick hit questions. And the first one is, do you have any passions or hobbies outside of neurology?
I grew up on a farm a couple of hours west of here in Omaha, west of Omaha, and it is true, you can't take the farm out of the boy. When I retire, I want to be a gentleman farmer.
Sounds wonderful. What other specialty would you have liked to have attempted? If
I was very close to following John Powell Spellman into the growing early neurointerventional work. I was very interested in that. It was one of those things where circumstance really dictates. Ellen Roper left MGH, and I had the opportunity to take over neurocritical care, and it seemed like the best thing to do. But I've always wondered, it would have been pretty cool.
Mm-hmm. And what specialty would you not like to do?
GI.
Maybe along those lines, is there a sound or smell in the ICU that you like?
I think the thing that I find most distinctive is that smell of melena in the morning when you walk in the ICU. I've spent enough time at Hopkins ICU that I will never forget that. It's kind of nice once in a while to recall.
Well, if that's nice to recall, then what's a sound or smell in the ICU that you hate, the one that you can't stand?
DMSO,
Mm.
the onyx embolization AVMs.
Yep. And then finally, what advice would you give to a fellow about to graduate?
It's a exciting time, and I think my advice would be relax, don't be too hard on yourself. It's going to be a rocky transition. You're going from a fellow who knows everything about everything, but has been responsible for nothing, to your first year in faculty is being responsible for everything and realizing you don't know everything. And it's a tough go. I've seen this transition, people struggle with it, some more than others, but just relax, it'll work.
Well, I think that's very wise advice, and it is a very humbling transition. Dr. Daryl Gress, thank you so much for coming on the podcast. We really learned, I think, a lot about both the origins of neurocritical care on the West Coast, and the way that training of fellows has changed over time, and the glimmers of hope that give us excitement for the future. So I can't thank you enough. We really enjoyed it.
And thanks for the opportunity.
All right. Well, you've been listening to the Neurocritical Care Society podcast. This podcast is available anywhere you download your podcasts, and continuing education credits are available for select episodes. We look forward to having you join in next time. Please like or subscribe.